Hi, this is Dr. Sarfraz Beg. I bring greetings from Digestive Surgery Clinic based out of Bellevue in Kolkata. And today I'll be presenting a case of an early dumping after Roux-en-Y gastric bypass. This was a lady, 50-year-old, who was hypertensive and had a history of Roux-en-Y gastric bypass 10 years back. She had lost from 98 kgs to 62, which was her nadir weight, and she had regained back to 75 kgs. She complained of postprandial giddiness, palpitation, syncope, and diarrhea. On further history taking, she revealed that she had a problem of encephalitis 2018, which led to some partial residual eyesight problems. She also had an occult papillary carcinoma thyroid, for which she was under surveillance for the last 1 year. These seem to be unrelated to the problem that we are about to discuss. On evaluating her for the dumping, which appeared to be the probable diagnosis, the 6-star score was 23. And we know that score more than 7 is significant for or suggestive of dumping syndrome. If we look at the 6-star score, we find that there are plenty of symptoms which are related to GI disturbance and vasomotor disturbance, which are given plus points, whereas some symptoms like eructation and vomiting, which signify anti-peristalsis and retrograde peristalsis as -1 and -4 respectively. So this is a very important way of differentiating GI symptoms, whether they are related to dumping or not. There, of course, remains a very important issue of differentiating between early and late dumping, and here ARTS questionnaire is very helpful. If we look at the two symptom set of early dumping and late dumping, what is significant to note is that in late dumping, which is caused by hypoglycemia, compared to early dumping, which is caused by hypertension, in late dumping there is hunger and irritability, whereas in early dumping that is not the case. In early dumping, however, one tends to find GI disturbance in the form of diarrhea, bloating, and abdominal pain. The endoscopy in this patient revealed a patulous gastrojejunostomy, which is predictable since early dumping signifies rapid passage of hyperosmolar chyme from the stomach into the distal intestine as the principal etiological factor. The oral glucose tolerance test showed these particular uh, values of packed cell volume, insulin and sugar and pulse rate, and this was done at fasting 30 minutes, 60 minutes, 120 minutes, and 180 minutes. To make this busy slide a little less busy, let's look at the packed cell volume and pulse rate only initially in this slide. We can see that the fasting packed cell volume was 41.6, which increased to 43.82 at 30 minutes, suggestive of hemoconcentration. We know from the consensus that a rise in 3% is significant of early dumping. So this was almost there. The pulse rate increased from 75 to 110 at 30 minutes, falling and normalizing at 180 minutes. This rise is very significant. A rise of 10 beats per minute itself is suggestive of early dumping, so this was definitely very classic. Let's look at the other aspect of the glucose tolerance test in this patient, and that is the measurement of insulin and sugar at these time points. And what we can see is that the sugar levels are 86 at fasting, and at 180 minutes also is 89, but at 120 minutes is 142 as well, which is all fine. However, at 30 minutes and 60 minutes it is way beyond 200. It's 257, 264, suggesting that this patient has got impaired glucose tolerance, and this should be labeled as diabetic patient. During these time points, one can see that the insulin levels are at supranormal levels, and therefore this is probably indicative of insulin resistance. So the interpretation in summary from this oral glucose tolerance test, modified of course, is that there is a hemoconcentration at 30 minutes, which suggests early dumping. There's a pulse rate which is very high, 30 minutes, again suggestive of early dumping, which happens because of the sympathomimetic activity. And the postprandial blood sugar at 2 hours and 3 hours are okay, but it is high at 30 and 60 minutes, suggesting that this patient is diabetic. One must know that there is no post-bypass hypoglycemia or PBH in this patient, which is important to note because many of these early dumping patients can have late dumping as well. And if you note the insulin levels, they are high at 60 and 30 minutes. That's supernormal, suggestive that there's an insulin resistance, since because of hyperinsulinemia, we expect a hypoglycemia or a normal glycemia, but in this patient there was high blood sugar level. The treatment that we advised her first was dietary, and this was already given before she reached our center. And she was advised to take frequent small meals, 60 grams of protein at least, and to avoid sugary drinks and beverages and sweets and fried food. She was advised to eat slowly and to consume the proteins first. She was advised that she should not have water along with the food and to take supplements. All of this she was doing. However, she did not respond to this therapy. When we got her, we advised her these things further. One, lie down for 30 minutes after consuming meals, and we asked her to take pectin powder dissolved in water with each meal, and we also started her on injection of tritide 50 milligrams subcutaneously before each meals. With these advice, which we have given earlier to other patients with early dumping, she responded and she did well. Also to note is in this patient, because we diagnosed her as diabetic because of the high postprandial glucose level at 30 minutes and 60 minutes, we started her on metformin and pioglitazone, not a GLP-1 agonist, as because that's not the first line recommendation in post-bariatric patients. She showed prompt recovery. There was resolution of symptoms, and even at 1 month of follow-up, she says that she's never felt better. On evaluating the published literature on this topic, there aren't too many. What we can see in the 1970s and 80s, it was believed, and it is still believed, that the dumping occurs because of rapid passage of hyperosmolar chyme to the distal intestine because of esophageal or gastric surgery. Recently, the bariatric surgery has come up as the commonest reason for dumping syndrome. Classically, there is osmotic extraction of water from the plasma, and that leads to hypotension and diarrhea, and this is a classic early dumping syndrome. Uh, in many patients, there would also be rapid absorption of glucose, which will induce a stimulation of beta cells, leading to hyperinsulinemic response, which results in hypoglycemia, and that is a classical late dumping syndrome. It is important to distinguish between the two because the treatment of these two are not the same as far as pharmacology is concerned. Uh, Although these are the classical etiology, recent research published in 2019 showed that the hormonal responses may also be responsible for early dumping in the form of GLP-1 and PYY. And this paper also suggested something pretty dramatic, and that is that almost a quarter of patients of Roux-en-Y gastric bypass probably have early dumping. So that's something to really, really note and observe. Well, is dumping caused only by carbohydrates? Is it caused by fat as well? In this paper, this research carried out in 2017, they found that the pulse rate increased not only to the carbohydrate meal but also a fatty meal, although the pulse rate increase was higher with the carbohydrate meal. Many times surgeons tell the patients, well, dumping is good for you because it disallows you to make bad food choices. However, many patients do not think so, and some patients may be really distressed with the dumping, such as the one which we are discussing today. The modified oral glucose tolerance test is the most important test for confirming dumping. A 6-star score, if it's more than 7, would indicate, and then once that is so, it should be confirmed with an OGTD test. And the classical finding would be an increase in hematocrit level of more than 3%, an increase in pulse rate by more than 10. In this patient, it was 2.5% and more than 10 definitely, 35 beats per minute rise was there at 30 minutes. And this comes from the international consensus which was published last year. uh, Many patients will have a coexistence of early and late dumping, and in this paper, they looked at patients who were confirmed post bypass hypoglycemia, and they looked for whether they had associated early dumping, and they did find on the OGTD test that there was a hemoconcentration and rise in the pulse rate, early suggestive of early dumping. So it does seem that there is a neurohumoral response which is common to the etiology of both kind of dumping. In terms of intervention, or for patients who do not respond to drugs such as the octreotide, in this case, which works by diminishing the secretion, altering the GI motility, and that shows dramatic results and good results, such as in our patient. There are reports of patients who have had to undergo surgery in the form of the reversal of Roux-en-Y gastric bypass, and in this systematic review they found that this was the second commonest reason for reversal after malnutrition. And recently, endoscopic outlet obstruction in the form of TOR has shown a success rate of 97%, but we must understand that this follow-up was only for 3 months. And this comes from a trial based both in US and Germany. So the take-home message is that early dumping is a common issue occurring years after Roux-en-Y gastric bypass. It seems that almost a quarter of these patients have early dumping. And unlike our own belief, some patients find it really distressing and something needs to be done. We first need to be aware that an oral glucose tolerance test it's an important method to diagnose it, and the interpretation of OGTT is crucial. Surgeons should learn, the bariatric surgeons and the team should learn how to interpret the OGTT. Initially, dietary modifications are helpful in many patients. However, there would be patients who will not respond, and in terms of early dumping, octreotide injections really help. So does pectin powder. For late dumping, which is not the subject of discussion today, there are drugs like diazoxide acarbose, which has been shown to be of value, and even octreotide in those cases. And it does seem, because of a common neurohormonal etiology, it's possible that there is an overlap of pharmacological treatment for these dumping. Finally, there are some patients who would require endoscopic outlet reduction in the form of TOR and reversal of Roux-en-Y gastric bypass as last resorts. And I would just mention that a pancreatectomy would be a very, very drastic way of managing a late dumping. So with that, I leave you with thoughts and would be very happy to answer any question, or in fact have suggestions regarding this particular problem which we have been seeing in our bariatric patients, especially the gastric bypass. Thank you very much.